Hello, welcome back for part two of the central nervous system. We are going to pick up right where we left off, and we're going to start looking at the functional brain systems. So, what that means is the different parts of the brain that work together to allow us to see or be who we are. And that makes up our limbic system and our reticular formation. So, what is our limbic system? It's in that middle part of the cerebral hemispheres. It's also contained within that diencephalon. If you remember from the pictures we've kind of looked at of the brain, we have that fornix. And that fornix is what's going to link the different regions of that limbic system together. And our limbic system deals with a lot of our emotions, our affective brain. So we have our amygdaloid body. It's how you can tell when somebody is angry at you, or maybe they're fearful of you or something else. You never know. It allows you to determine what danger is in front of you. So, how do you respond to fear? That all comes from that amygdaloid body. So, when something scares you, do you jump? Do you not really react to fear? I'm sure everybody has some kind of fear response, even if they don't realize it. We also have our cingulate gyrus. Our cingulate gyrus allows us to express motions via gestures. And it helps to resolve some of those mental conflicts that go on in your brain. When you think about, should I do this or should I do this? Is this better or is this better? That all comes out of that cingulate gyrus portion of the brain. So here shows the different parts of the limbic system. So here's the diencephalic structures, which includes that anterior thalamic nuclei, that hypothalamus, and that mammillary body. We have this fornix, that anterior commissure, that cingulate gyrus, the septal nucleus, the amygdaloid body, hippocampus, dentate gyrus, and parahippocampal gyrus. That all makes up portions of our limbic system here. So I know I mentioned this in the part 1 video, but your limbic system associates the skunk with they smell bad. Most of the information from the limbic system actually gets relayed via the hypothalamus. So that limbic system sends that information to the hypothalamus. The hypothalamus sends that information out to where it needs to go. They also play a role in psychosomatic illness. That psychosomatic illness is some kind of illness. It could be because of a mental factor, like stress. Stress can play a huge role in psychosomatic illnesses because stress does a lot of weird things to the body, depending on how long your body has been under that specific stress. That limbic system is going to interact with the prefrontal lobes, and that's how we react to different stimuli around us. But it also makes us aware of all the different emotions that we encounter in our lifetime. It's kind of cool. How about that hippocampus and that amygdaloid body? Of course, they're going to help with your memory. They're going to help you remember specific things throughout your day. They're going to help you remember when you're studying. What about that reticular formation? That reticular formation, I know we've looked at it a little bit, but it goes from that central core of the brain stem, and it runs the entire length of that brain stem. So we have that raphe nuclei. We have a medial group of nuclei and a lateral group of nuclei. And they all help to connect the brain's arousal through all these different portions of the brain, that hypothalamus, thalamus, cerebral cortex, cerebellum, and spinal cord. All these different areas need to be connected together somehow. Well, that reticular formation is going to help connect everything together. So we have a reticular activating system, or RAS. So that reticular activating system takes information, sends it to the cerebral cortex. That's how we stay alert about something. But that reticular activating system, it filters out things, repetitive signals for something that's not necessarily necessary to know. Familiar things. Sometimes it'll filter out familiar things so you can focus on something new or different. Even weak stimuli gets filtered out. Like 99% of the information coming through this reticular activating system, your brain isn't even like conscious of, or doesn't make you conscious of that. It's kind of interesting because that's a lot of information that's coming in, but it just depends on if your reticular activating system decides that you need to know about it or not. Your sleep centers can inhibit this reticular activating system. This is what allows you to actually sleep, because it's supposed to help quiet your brain down so you can fall asleep. I know some people have a problem with getting their brain to stop making them conscious of all kinds of different things, but your sleep centers are supposed to be inhibiting this. Alcohol and drugs, they can also inhibit this, which can make you aware of all kinds of things you don't need to be made aware of. It does a lot of interesting taking certain drugs. illegal drugs, those will cause you to become aware of things you don't need to. But what happens if you have if you have a very severe injury to this reticular activating system? That's where permanent unconsciousness or that coma comes in, and it could end up being part of what makes somebody brain dead. So we have a motor part of that reticular formation, and it helps to form some of our movements, limb movements, so arms and legs, but it's not like precise movement. It helps with like the grand, large movements to an extent. And it uses the reticulospinal tracts to help form or control some of these limb movements. We also have vasomotor centers in the reticular formation, cardiac centers, and respiratory centers. So here is this reticular activating system. So we get sensory information that comes in from the spinal cord. We get sensory information in from our eyes, our ears, sensory receptors. They all come into this reticular activating system. The reticular activating system is going to send that information to the cerebrum through that thalamus, because that thalamus kind of determines where that information needs to go. And as more information keeps coming in, it keeps you aware of what is happening, certain things. Like it's too hot. Sometimes, depending on where you're at, that it's so hot, it can your body can actually keep you aware of that being too hot for quite a while. So here's major regions of the brain. We have our cerebral hemispheres. This charts talk about what the gray matter is and what it does. The basal nuclei, those are subcortical motor centers. They help with your skeletal muscle movement. Our thalamus, that's what relays information to that cerebral cortex. It kind of determines as information comes in where it needs to go. That hypothalamus, it helps, does your autonomic nervous system, limbic system, emotional responses and memory processing. That midbrain has visual and auditory reflex centers, has motor centers, cranial nerves, has projection fibers from pyramidal tracts. We have our pons. It takes information from the cerebellum or cerebrum to the cerebellum. There we go. It helps with respiratory response, control, rate, that how deep you're breathing. All of that is being controlled in the pons. We also have projection fibers that go through the pons. The medulla. It has sensory information that is coming from the body, and it takes that information through nuclei Cuteus and gracilis, and relays that up to the brain. It also controls your heart rate, blood vessel diameter, respiratory rate, vomiting and coughing. Sensory information. It's going to the cerebellum. More projection fibers, and it also is where those motor fibers are going to cross on their way out of the brain. A reticular formation keeps you alert, but it filters out repetitive stimuli that you don't need to know about. But it regulates muscle activity. Cerebellum. It processes information. It kind of helps bring everything together and sends out instructions on how to do something. Your balance, your posture, all of that is coming from that cerebellum. What about higher mental functions? We do a lot of higher mental functions throughout our day, such as anytime you speak, your memory, anytime you recall something. What about brain waves? Or consciousness, sleep-wake cycles. We talked about this a little bit already, but our language, that Broca's area, allows us to form words. It works with understanding words. Because someone that has a lesion to Broca's area, they're going to understand those words, but they can't speak. So Broca's area gets injured. They have no problem understanding what you're saying, but they're not going to be able to respond to anything. Versus Wernicke's area, they can speak, but their sentences make zero sense. They're just a bunch of words, random words strung together in some random order. Wernicke's area is what allows you to understand the words you're hearing and the words you're reading. These are both in the left hemisphere. Broca's and Wernicke's, left hemisphere. In your right hemisphere, they have those areas are involved with some form of nonverbal language components. But here is that Broca's area. Through here. Here is that Wernicke's area. Memory. We have different kinds of memory. And your memory is being able to pretty much store something away somewhere and being able to recall it. This is what we should be doing when we're studying anatomy, is that we are learning it, storing it in our memory so we can recall it at a later time. Not just cram everything in to dump it out on a test, because that will not help us down the road when we come across certain problems again. Certain things where we may need this kind of memory. So we have declarative memory. That's facts. That's a lot of anatomy, actually. But it remembers names, faces, words, dates. Procedural memory. How you do something. Remembering how to make dinner. How to play the piano. motor memory. It's how you move. There's memory of how to do something, even if you haven't done it for years. Like, right, if you haven't ridden a bike in years, you still have memory in your brain on how to do that. Also, that emotional memory. Something like some kind of experience that elicits some kind of emotion. We all have different emotional memories, just depending on what kind of experiences we've had. But yeah, if you were to come across a snake, I mean, some people don't mind snakes. Other people do. Other people are scared to death of them. And yes, their heart starts pounding really fast. That's an emotional response to seeing or hearing a rattlesnake for some people. Your short-term memory. Your short-term memory is something that you're going to hold on to temporarily and then forget. It will be kind of whisked away somewhere where it's not used. This is what a lot of people like to try to do in school when they take tests. What they do is they try to store as much information in that short-term memory and go dump it out on a test somewhere. They keep it in their short-term or working memory, which means they're never going to recall it again after that test. What we need to do is put it into long-term memory because we have limitless capacity. You can keep storing more and more and more information into that long-term memory. So these are some good tips for when you're studying right here. To transfer information from short-term memory to long-term memory, best if you're alert. You're awake, but not just awake, but you're conscious of what you're doing. Some people try to study when they're really, really tired and it doesn't work because they are not completely alert. You have to be motivated. You're going to need to want to learn something. Aroused. There's some pretty cool studies out there that actually say if you exercise while studying, it helps you remember things better. That's an idea. Rehearsal. This is where I always say flashcards, flashcards, flashcards. Repetition and practice. Using flashcards, you're constantly going through this information over and over and over and over again. That is that repetition that takes that information from that short-term memory to that long-term memory. What works for some people is trying to associate new information with old memories. It works for some people. It works for some things really well, but it doesn't work with everything. And sometimes it can be really hard to find associations for everything. That's a lot of information to try to put out or try to find information to match up something else with. We also have our automatic memory. I mean, it would be really nice if everything could work the same way as our automatic memory because I mean, that's where subconscious information gets stored into long-term memory. That'd be great if studying worked that way, but studying is not subconscious. You can't subconsciously study. It would be great if we could, but unfortunately, it doesn't work that way. As our memory keeps getting built, keeps getting put together, we're going to take new information And we're going to kind of categorize it into information that's already stored there. It's kind of helps to keep things nice and orderly so we can recall things easier as needed. Our hippocampus, our temporal cortical areas, that thalamus, and that prefrontal cortex all help to consolidate new information into already stored information so we can pull things out again as we need them. So here's how our memory storage kind of works. We get some kind of outside stimulus. Could be studying, could be a smell, you could hear something sharp. It goes into that temporary storage. Some things, probably something sharp, something that smells bad, is going to go straight through automatic memory into long-term memory. But it doesn't, not everything does it. A lot of things go into that temporary storage. And then as it goes through that temporary storage, it's either going to go to permanently lost, you forget it, or it's going to go to that short-term memory. And that short-term memory is either going to be forgotten or through rehearsal, some kind of excitement, exercise is part of that, association, it'll get stored into long-term memory. The problem is with long-term memory, certain things, you ever hear the term, you don't use it, you lose it? Well, that can happen to our long-term memory. You don't use it, you lose it. So data becomes unretrievable if you don't use it. But from your long-term memory, if you go back and you use it, oh, well, we just retrieved it. It goes back to short-term memory, so we can use it. Then it goes back down to long-term memory again. That's how our memory works. But what happens if we have some kind of damage to that hippocampus? That hippocampus plays a pretty important role in our brain. That hippocampus, or maybe even that temporal lobe around it. It could, if it's on one side, it could have slight memory loss. But if we have damage to both sides, it's when amnesia comes in. You can't remember anything. We have two different kinds of amnesia. Anterograde amnesia. That is where you remember everything that happened before whatever event caused that anterograde amnesia. You just can't remember anything new. You can't associate old information with whatever new information is coming in, so it's not remembered. These people have about a memory of about 5 minutes. You're talking to somebody for more than 5 minutes, what you started that conversation with, about 5 minutes in is gone. Retrograde amnesia. Retro goes back. So that is when we lose our memories from a long time ago. You can remember what's happening now, tomorrow, what happened yesterday, even last week, last month, maybe even last year. But in that distant past, you don't remember anything. So we have different ways of measuring brain waves. If anybody's ever had any like an EEG before, it's where they actually measure your brain's ability to function. And we talked about this in muscles, but your nerves and muscles use electricity to conduct, which is why we can use an electro or an electroencephalogram to record that electrical activity that is happening in the brain. People who have epilepsy, this is how they track and find epilepsy. Sleep disorders. They'll even use it to find lesions in the brain, tumors, an infarct, infections, abscesses. They can also determine brain death through an EEG. They put electrodes all over the scalp and they measure out your brain activity. So I know I've mentioned this in class before, but just how every person's body is different. Every person's brainwaves are unique to that person. They're going to be different. And they're going to change depending on how old you are. Any sensory stimuli? So you're looking at something that's actually stimulating that visual cortex. Are you moving? That stimulates that motor cortex. Are you thinking? So that stimulates a lot of the brain. What's going on that changes your brain waves? Brain disease does. The chemical state of the body. We use hertz to measure brain waves. Hertz is the numbers of peaks per second. So 1 hertz is 1 peak per second. Then we have alpha waves, beta waves, theta waves, and delta waves. So let's look at those. Alpha waves. Brain's not doing much. It's pretty idle. It's low amplitude. They're pretty regular. You're sitting on the couch out looking out the window. Not much is going on. Beta waves. I'm sure you've got some pretty good beta waves going at this very second, because that's when you're mentally alert. So you're doing something. Well, you're listening to a lecture right now, so you're mentally alert. You should be mentally alert. So you should have some beta waves going at the moment. Theta waves are more common in children. And they are uncommon in awake adults. Delta waves. Deep sleep. Amnesia or anesthesia. If we see delta waves in an adult when they're awake, that it signifies brain damage. So that's a way to check some of these. You look for these, you look for these. You look for what kind of waves are happening at different times. If somebody's got a bunch of delta waves going on, something's not right. So here's the different types of waves. Our alpha waves are pretty consistent. Beta waves, you're studying, you're doing something consciously, you're cleaning something, paying attention to something. Theta waves, Theta is in children. Theta waves are in children. Delta waves are sleep. Delta waves are sleep. Delta waves are when you're asleep. If you're awake with delta waves, there is some sort of brain damage. Epileptic seizures. An epileptic seizure? And it's when a bunch of neurons discharge or send out action potentials that shouldn't be. So messages that should be getting through to the brain in that area are not, because there is nothing going through. Somebody with epilepsy, they can lose their consciousness. They fall to the floor usually, and they have some sort of uncontrollable jerking. Those used to be called grand mal seizures. The people that you see the uncontrollable jerking, they lose consciousness, they fall over. They're tonic-clonic seizures now. They like to change names up on things just because. Epilepsy is not associated with any kind of intellectual impairments, and it only occurs in about 1% of the population. Genetics, as always, genetics plays a role in everything. What about brain injuries or a stroke? Even infections and tumors can be a cause of epilepsy. That's why they usually, if somebody starts getting these seizures, they start looking into what is causing these seizures. Before somebody has a seizure, they sometimes may have some kind of aura or a sensory hallucination. We have an absent seizure. This is where somebody may kind of black out for a couple seconds, and then they come back. Like, you can see that they just kind of, they're there, but they're not there. And then they come back around. Then those tonic-clonic seizures I just mentioned, that is the one where you see that jerking, those convolutions. They usually have loss of bowel and bladder control during a tonic-clonic seizure. They can bite their tongue. They lose consciousness. Sometimes they can break their bones, depending on how intense these convolutions can be. So they have these anti-convolusive drugs out to try to help prevent people from having these tonic-clonic seizures specifically. I mean, they'll use them for these absent seizures, but they usually they want to help stop those tonic-clonic seizures. So they have a vagus nerve stimulator or a deep brain stimulator implantation that can help to kind of stabilize that brain activity. It gives pulses to that vagus nerve. The vagus nerve is one of our cranial nerves. But it deals with a lot of different things. When we get to cranial nerves, we'll see everything that vagus nerve does. It does a lot. Consciousness. What is our consciousness? some kind of sensations. Voluntary inhibition and control of movement. Higher mental processing. It all happens when we're conscious. We have kind of this continuum of our behavior in response to stimuli. Your alertness versus drowsiness, stupor, and coma. These all kind of are used to describe different states of consciousness. So current thoughts on consciousness kind of involves different areas of the brain communicating with each other. So things are happening, your brain is talking to each other, it's doing something. We have superimposed on other neural activities. Get this holistic and totally interconnected consciousness going on. Unless you're sleeping, a loss of consciousness usually signifies something is happening. Something is wrong with the brain. Fainting or syncope. Syncope is another name for fainting. That's when you lose consciousness briefly. A lot of times it's due to blood flow to the brain. You're not getting enough blood flow. Could be because of low blood pressure. Could be from hemorrhage, severe emotional stress. Fainting is kind of your body's way of trying to restore a lot of times that blood pressure or that blood flow to the brain. A coma. You're unconscious for an extended period of time. It's not deep sleep. That's something different. During a coma, you don't have a lot of oxygen consumption going on. Versus brain death. We've mentioned it a little bit before, but that's that irreversible coma. And that's where, in this country, there's a lot of ethical and legal decisions about whether a person is actually dead or alive during brain death. Let's look into our sleep-wake cycle. Sleep is defined as a state of partial unconsciousness from which a person can be aroused by stimulation. There's decreased cortical activity, but your brainstem activity is still going like it is right now. So we have our non-rapid eye movement sleep and our rapid eye movement sleep. That non-rapid eye movement is in 4 stages. Within the first 30 to 45 minutes of sleep, we pass through those first two stages of non-rapid eye movement sleep. And then we move into stages 3 and 4, or slow wave sleep. Remember we looked at those brainwave frequencies? That slow wave sleep is where the frequency of the waves decline, but your amplitude of those waves increases. So amplitude goes up more. You can run an EEG while somebody's in their sleep cycle. The heart rate is going to change. The respiratory rate changes when you're sleeping. Your blood pressure changes. Even your GI motility changes. That's the last thing you need to do when you're sleeping, is to wake up to defecate. So at about 90 minutes into sleep, we hit REM sleep. During REM sleep, our muscles are actually in a temporary paralysis. Technically, during REM sleep, we cannot move our muscles except your eyes. That's why it's rapid eye movement sleep. Your eye muscles are the only things that actually move. We increase the amount of oxygen we take in during REM sleep. Our heart rate goes up. Our breathing increases. It could be even greater than when we're awake. It just depends on each situation of REM sleep. We dream in our REM sleep. So here are the different types, or the different stages of sleep. Awake, a REM sleep, where your skeletal muscles are inhibited, except we said those ocular muscles. It's also the diaphragm, because you need your diaphragm to breathe. We have non-REM stage 1, non-REM stage 2, non-REM stage 3, non-REM stage 4. You can see how the waves just get larger and larger and larger. And what happens during those different stages? Like non-REM stage 4, bedwetting, night terrors, sleepwalking occurs. So anybody who does any of that, that's happening during that non-REM stage 4. So our sleep is regulated, of course, by our brain, our central nervous system. We have this natural circadian rhythm, which is a 24-hour rhythm. Our reticular activating system is inhibited during sleep. So we are not being made consciously aware of all this stuff happening when we're trying to sleep. We have suprachiasmatic and preoptic nuclei in that hypothalamus that help time your sleep cycle. When it's time to wake up, your hypothalamus has this hormone called orexins, and that helps to wake that cortex of your brain up, which eventually wakes you up. Your sleep pattern. We're going to go back and forth between REM and non-REM sleep. We go through those stages. You go through that non-REM sleep, you go into REM sleep, then you go back to that non-REM sleep, then you go back to the REM sleep, and it cycles over and over again throughout the night until morning. So here's a typical pattern of sleep. You see all the different stages in the different hours. You go to REM, stage 1, 2, 3, 4 of non-REM, back up to REM, stage 1, 2, 3, 4 of REM, non-REM, REM. This is over a 7-hour, almost 8-hour period, 7.5 of one night's sleep. You can see it gets closer and closer to being awake, even by like 3 hours in sleep, 3.5, almost 4 hours. You don't hit stage 4 anymore. Then about 5 hours, you don't even get to stage 3 of non-REM. And you notice that REM sleep gets longer. So why is it so important to sleep? That non-REM stage 3 and 4, or the slow wave sleep, is thought to be the restorative stage of the body. Because if you're not getting enough REM sleep, that's when people get really moody. They start to get really, really crabby. They can get really depressed if they're not getting enough sleep. That's where some people actually start getting depressed. REM sleep actually allows you to analyze the day's events and work. It also eliminates unneeded synapses that were formed. We dream to forget sometimes. So as we get older, how much sleep our body needs actually starts to decline. That stage 4 sleep, it continues to decline with age. Sometimes after 60, we don't even get to that stage 4 sleep anymore. So that restorative stage, we don't hit it as we get older. Narcolepsy. Narcolepsy is somebody who can actually they just randomly fall asleep. It could be related to something that's happening, but they go from a lapse into sleep from a wake state at any moment in time. It could be really dangerous if somebody has narcolepsy and they're driving because they could just randomly fall asleep. We have cataplexy. It's actually a form of narcolepsy where they lose their muscle tone, but they're still awake. You usually lose your muscle tone during that REM sleep when you get that temporary paralysis. Well, that happens in cataplexy. Or that orexins, which is that wake up chemical. That person's immune system destroys it. So that person doesn't wake up. There is replacement therapy of orexins that can be taken to help somebody wake up. Insomnia. That is where you're not getting quality sleep. Could be depression, anxiety, overuse of caffeine. Some people notice that if they have caffeine after a certain time of the day, they don't sleep at night. Other people can have caffeine right before they crawl into bed and it doesn't affect them. But for some of us, too much caffeine means we aren't going to sleep. If you're using your computer or your cell phone too close to bedtime, those screen colors, that brightness of that screen makes it a lot harder to actually fall asleep. People who use or that have insomnia, what they do is they take some drug that will help block that orexin activity so they can actually fall asleep. So I mentioned it before when I was talking about cerebrospinal fluid in part 1. Well, let's look at what actually wraps around and protects our brain. I had mentioned that these are called meninges. These meninges are going to help protect your brain. Just like when we talked about muscles, there's layers to the muscles, there's layers to the bones, well, there's layers to the brain and the protection of the brain. It helps to protect the blood vessels around the brain. And we have these venous sinuses where blood drains before it drains out of the brain into the jugular veins to go back to the heart. I had mentioned that it contains cerebrospinal fluid. But these meninges also form partitions in the skull. It helps to kind of protect the different areas of the brain. The different layers are called the dura mater, the arachnoid matter, and the pia mater. Dura is the most external, it's on the outside. Pia mater wraps right directly around the brain. So here's a direct cut through the scalp. You can kind of see you have the brain down at the bottom, and then you have even part of the skin of the scalp at the top. So let's look. We have that pia mater that lays directly on top of the brain. We have that arachnoid matter. That arachnoid matter has a little space between it and the pia mater. We've got blood vessels that go through there. And we're going to have that cerebrospinal fluid going through there. We also have that dura mater. That is the most external layer. So that dura mater, since it's the most external layer, it's the strongest of the meninges. And it is made up of a periosteal layer and a meningeal layer. Think about that periosteal layer. It's going to actually attach to the skull. Periosteal, well, that has to do with bone, so it must attach to that bone. The meningeal layer is that true external covering of the brain. And it's going to form a dural venous sinus in areas. And as I had mentioned before, those venous sinuses is what collects the blood that actually goes into those jugular veins of the neck. That dura mater is what helps to kind of separate the different parts of the brain out. We have a dural septa. That dural septa is in 3 parts. We have the falx cerebri. That's that nice longitudinal fissure. It goes through that separates the right and the left hemispheres. The falx cerebelli. Remember how we have those right and left hemispheres of the cerebellum? Well, it's going to go right through there. And then we have the tentorum cerebelli. That actually separates the cerebrum from the cerebellum. So here are these different parts of that dura mater. That falx cerebri separates right and left hemispheres. Tentorum cerebelli separates the cerebrum from the cerebellum. And then that falx cerebelli separates the right and the left hemispheres of the cerebellum. So here's how you see it on an actual brain. You can see the white covering on the right side of the picture. That is actual dura mater that was left over the brain, versus the left side. You can see how the brain is underneath all of that. That arachnoid mater is that middle layer. Is that it has a spider web-like extension. And it is separated from the dura mater by that subdural space, subdural below the dura. We also have a subarachnoid space, as I had pointed out in the picture a few slides ago. That's where that cerebrospinal fluid goes, where blood vessels are. And then we have the arachnoid granulation. And that's what goes through the dura mater that helps with the superior sagittal sinus. And that's where we reabsorb cerebrospinal fluid back into the bloodstream. So again, here's that picture. You see this falx cerebri? That's this portion going down. You see this arachnoid matter, the subarachnoid space. This is where that cerebrospinal fluid is going to flow. It has those major blood vessels as well. Pia matter. Pia matter, as I've said, clings to the brain. It attaches right to the brain surface. It also has a lot of tiny blood vessels because our brain is in constant need of oxygen and nutrients to keep functioning properly. So all of this information, this pia matter is all keeping our brain supplied with our nutrients. If you've ever heard of meningitis, it has itis, which tells us it's an inflammation of something. And it's meninges, meningitis, meninges, inflammation of the meninges. It can spread to your central nervous system, in which causes to inflammation or collection of fluid and inflammation into that brain, which is then referred to as encephalitis. They do what's called a lumbar puncture. They stick a needle into that spinal area and they draw out of that cerebral spinal fluid to test it. They're looking for microbes. They're looking for things that are in your cerebral spinal fluid that shouldn't be. As I have mentioned before, as I've talked about cerebrospinal fluid, but it's a cushion. It gives buoyancy to your brain, but it also reduces the weight of your brain by a lot, by 97%, because your brain is floating in the cerebrospinal fluid. If you were to get a blow to the head somehow, that cerebrospinal fluid is going to help protect your brain. But it also nourishes your brain, because we need nutrients to help keep our brain functioning. And I said before, it comes from blood plasma. But it has not as many proteins and different ions than your blood plasma does. As we said when we talked about that choroid plexus, where it was located, that choroid plexus is what makes it cerebrospinal fluid. It's capillaries, where that plasma comes out of the capillaries, and it helps to make that cerebrospinal fluid, and then it is lined with these ependymal cells. Your ependymal cells help to get ions into that cerebrospinal fluid in the correct proportions. It cleans the cerebrospinal fluid. It removes different wastes. They also have that cilia on top because they need to keep that cerebrospinal fluid moving. We have about 150 milliliters of cerebrospinal fluid, and it is replaced every 8 hours. So it is constantly being replaced over and over again. Almost twice in a day, our cerebrospinal fluid is being replaced. Twice in a 3 times in a 24-hour period. So here shows our choroid plexus at number 1 is making that cerebrospinal fluid, and it is circulating that cerebrospinal fluid through the ventricles, through that central canal, into the spinal cord, and around the entire brain to help lighten the weight of that brain because it's floating. So here are these capillaries coming down and through. You see they're a single layer, a simple squamous epithelium. And because it's a simple squamous epithelium, it allows things to pass through it very easily. So it allows these wastes and unnecessary solutes to go back into the bloodstream, while plasma, glucose, oxygen, vitamins, and ions filter out to help take care, get our brain and our cerebrospinal fluid what it needs. Hydrocephalus. Hydrocephalus is when we actually have some kind of blockage in our cerebrospinal fluid somewhere. So it's not draining the way it should. It's not flowing the way it should. And it results in having some kind of increased pressure in our skull. In a newborn, because their skulls are not fused, that pressure can enlarge greatly and their skull can become huge. But in adults, because our skull is fused, the pressure stays in there and it can cause brain damage if we have too much pressure, too much cerebrospinal fluid built up. So they drain that cerebrospinal fluid. Sometimes they'll put in some kind of shunt that shunts that fluid down into the abdominal cavity where it can be drained out. Here is a baby with hydrocephalus. Has a lot of fluid buildup in the brain, and since their skull is not fused, that fluid can keep expanding. I had mentioned the blood-brain barrier in part 1. We need to maintain a blood-brain barrier to help our brain function properly. Because if we have the wrong chemical variations, neurons can fire unnecessarily, uncontrollably. So that's why everything gets filtered as it comes into or goes through that choroid plexus. We have tight junctions between those ependymal cells because that only allows certain cells or certain particles, nutrients to come through. We have a lot of astrocytes and pericytes because those help keep those tight junctions. They help filter what's coming in and out of that bloodstream. Stuff can come in and out of cells by simple diffusion. We need lipid-soluble substances. We need oxygen, carbon dioxide. That'll go through simple diffusion. And then we have transport mechanisms because we need glucose, amino acids, specific ions to maintain that balance in our cerebrospinal fluid, but also give us glucose to make energy. We use transcytosis even to get larger chemicals or larger substances into or out of the brain for specific use. So here are those pericytes. You can see how they wrap around those capillaries. We even have those Astrocytes. They're helping to monitor what's coming in and out of the blood and into the cerebral spinal fluid. They are making sure only what we need is coming out and not what we don't need, like red blood cells. We do not want red blood cells in our cerebral spinal fluid. So as we just looked on that picture, they have a pretty thick basement membrane, that bottom layer that goes around those categories, those capillaries, because we want to keep what needs to stay in and only let out what should be coming out. But that thick basement membrane is not always there. It can be absent. Like in that vomiting center in our brain, that hypothalamus. Because we have to be able to monitor chemical composition of our blood. The hypothalamus needs to keep track of that. What chemical compositions do we have in our blood? Is it too much of something? We have not enough of something? Because we need to know if, we have too much calcium in our blood. That we got to go tell the bones to store some calcium away. We have not enough calcium going through our blood. We need to tell the bones to take up some calcium. We need some of that stuff. We need to monitor the temperature of the blood. Is our blood temperature getting too hot? Well, if it is, then we need to do something about it. If it's getting too low, we need to do something about that too. So let's look into some brain injuries and disorders. We're going to look at concussions. A concussion is a temporary alteration in function of the brain. A contusion, that's a permanent damage to the brain. Subdural or subarachnoid hemorrhage is when pressure from blood may force the brainstem through the foramen magnum. And that can result in death. Or cerebral edema. Edema is swelling. So we get swelling on the brain. Could be because of some kind of traumatic head injury. A stroke. Or a cerebral vascular accident. That is what the medical term for a stroke is. We end up with ischemia. Part of your brain is not getting blood, so they're not getting the nutrients it needs. And if that part of the brain isn't getting the nutrients they need, that tissue in that area is going to die. Could be from a blockage in an artery. And then glutamate, an amino acid. It can act as an exotoxin and worsen the condition even further. Hemiplegia. When you get paralysis on one side of the body. Or sensory and speech deficits that can result on one specific side of the body. So we have transient ischemic attacks, and that is where temporary episodes of reversible cerebral ischemia occur. We have tissue plasminogen activator, which is the only approved treatment for stroke. Try to break up that blood clot before it causes further damage. Alzheimer's. Alzheimer's is a progressive disease that results in dementia. Dementia is where you lose your memory, short attention span, disorientation, language loss, irritability, moodiness, confusion, hallucinations. Those are the main symptoms of Alzheimer's. And it's because of proteins in the brain get misfolded, so they malfunction. We end up with these plaques of beta amyloid peptides in the brain. We end up with neurofibrillary tangles that kind of interfere with the transport of information, and it kills off those neurons. As brain cells die, that brain shrinks because your nerves are the least capable cell in the body of replicating, of repairing. So here's a normal brain versus a brain of somebody with Alzheimer's. You can see how the brain has started to shrink down, how they're not able to use all parts of their brain anymore. Parkinson's. We had mentioned Parkinson's before. But Parkinson's, again, is that degeneration of that substantia nigra. We don't get the dopamine that basal nuclei needs. So it becomes overactive. And that's how the tremors result. Somebody who's got that shaking. We don't know what causes it, but there's a lot of different theories on what could be causing it. But they use this L-DOPA, which is a dopamine precursor, to try to help keep that basal nuclei getting the dopamine that it needs to function. They're also doing research into stem cell transplants to see if any of that can help. Huntington's disease. Huntington's disease is a fatal hereditary disorder because we have an accumulation of proteins, of the protein huntingtin in our brain. Again, that basal nuclei degenerates, but so does your cerebral cortex. They usually have some wild, jerky, flapping type movements. They end up with mental deterioration. It's fatal within 15 years of onset. They're going to take drugs that block that dopamine instead. They're also looking at stem cell transplant implants to see if that would help with Huntington's disease. So there's a lot of different ways that we can test the central nervous system to see what kind of problems are occurring. If you go into your physician's office, for a general checkup, they usually test that knee jerk reflex. With a reflex hammer, they tap that quadriceps or patellar tendon, and they're looking for either no response or a hyper. So a larger, an abnormal response above normal. It can indicate intracranial hemorrhage, MS, multiple sclerosis, or hydrocephalus. Just by doing that knee-jerk reflex, that can trigger a CT, MRI, or a PET scan to look for what could be causing that absent or hyper reflex. They can do a cerebral angiography, uses x-rays with a dye if they're looking for some kind of stroke. Ultrasounds, that can check the blood flow of the different arteries that feed into the brain. We've looked at everything in the brain. Now let's start traveling down the spinal cord. Let's look at how this information gets up to the brain or goes back down. So our spinal cord starts at that foramen magnum, that nice opening in our skull, and it ends between L1 and L2, lumbar vertebrae. And that spinal cord is going to provide communication between the brain and the nerves that are out in the body. It's also the reflex center, because your reflexes don't actually go up to your brain. They go straight into your spinal cord and right back out. I know we talked about that in the intro to the nervous system chapter. So here's that spinal cord. You can see it's around L2, L1, L2, that spinal cord ends, and then you just have free nerves. Those free nerves are called the cauda equina. Equina, because it's called cauda equina, means horse's tail. Somebody thought it looked like a horse's tail, so that's what they named it. So just like we have those meninges around the brain, we also have spinal dura mater. We also have bone meninges in that cerebrospinal fluid that's made in the brain and circulates through the brain. It circulates through that spinal cord. We have that epidural space. We have fat in there. We have veins. And it's between the vertebrae and that spinal dura mater. That cerebral spinal fluid, again, is in that subarachnoid space. It's between that arachnoid and that pia maters. That dural and that arachnoid membrane actually extends into the sacrum and beyond that L1, L2, where the spinal cord actually ends. That L1, L2 area is where they do those spinal taps. When they stick a needle in to check the cerebral spinal fluid for any kind of microbes or pathogens, that is all done at that level. So here is a view of doing a lumbar puncture. You can see they're down between the L4, L5. There's no spinal cord left. It is just a bunch of nerves that lead out, that go to L4, L5, nerves that come out, go down to your legs. So at the end of that spinal cord, as we said, that spinal cord usually ends between L1, L2. There is a cone shape at the bottom of that is called the conus medullaris. The filum terminale is a very bottom part that it goes all the way down to that coccyx bone, and it's going to anchor the spinal cord in place. Going all the way down the spinal cord, we have denticulate ligaments. It comes from that pia mater because it's going to help hold it holds to the dura mater, but it's going to hold that spinal cord in place. We have cervical and lumbar enlargements. And that is where, at that cervical enlargement, that is where the nerves that go to your arms come out. We have that lumbar enlargement. That is where the nerves that go to your legs come out. So once the nerves actually leave the spinal cord, they are considered to be part of the peripheral nervous system. And we have 31 paired nerve roots that come out of the spinal cord, one on each side, a right and a left, between each of the vertebrae going down your back. So each spinal cord segment has a paired spinal nerve that comes from it. We have that cervical and lumbosacral enlargements because that's what feeds our arms and our legs. And that cauda equina that I mentioned in that picture above, it means horse's tail because it's just a bunch of nerve roots at that point. So here is that picture. You can see the conus medullaris. The green going down, that is that filum terminale that anchors that spinal cord down by the coccyx. And you see all the different nerves that come out. Here is that cervical enlargement. You see these nerves coming out from that cervical spine. Here is that medulla oblongata at the top and the foramen magnum of the skull. You can see all the spinal cord coming out. Coming down, you see these nerves that are leaving out at every spinal level. Here's our thoracic spine. You see the same thing. You see that spinal cord. You see the dura mater. We have a dorsal root ganglion, which holds the cell bodies of nerves. And that lumbar. Again, here's that conus medullaris. The cauda equina. That horse's tail. That filum terminale, you can see it. It's a lot larger than the rest of the nerves around it because it's going to go anchor that spinal cord. So here's all the different segments. Our nerves are labeled for where they come out. We technically have 8 cervical nerves, 12 thoracic, 5 lumbar, 5 sacral, and a coccygeal nerve. So within our spinal cord, we have a ventral median fissure and a dorsal median fissure. Remember how with that chapter 1 I had you guys learn all those different anatomical terms? You see how they're coming into play? Ventral, front, dorsal, back. We have gray matter and white matter. Gray matter on the inside, white matter on the outside. That central canal through the middle that has that cerebrospinal fluid. Here is that spinal cord. Gray matter's on the inside, white matter along the outside. See that ventral median fissure. You can kind of see that posterior sulcus through there. Here it is from another view. You get that dorsal median sulcus. Ventral median fissure in the front. We have our white columns. We have our gray commissure with our gray matter. So as I said when I drew the butterfly, I drew the spinal cord to show that central canal towards the beginning of part 1. I said it kind of resembles a butterfly. Could be a letter H. There's 3 different parts to our gray matter in our spinal cord. We have our dorsal horn, ventral horn, and lateral horns. Those dorsal horns are interneurons. Interneurons connect a neuron from the periphery, so your arms, your legs, your body. It's going to synapse with an interneuron. Once the information comes into the spinal cord, that interneuron, which is the second neuron, is going to take information up towards the brain, where it'll synapse with another neuron before it gets up to that cerebral cortex. But that dorsal horn has those interneurons. It receives somatic, so muscle, and visceral sensory information. That ventral horn has interneurons and somatic motor neurons. So your motor comes from the front part of your spinal cord. Sensory goes up the posterior portion of your spinal cord. Lateral horns. We do not have a lateral horn in the cervical spine. We do not. We have it in the thoracic, in the upper part of that lumbar, and that is sympathetic neurons. Sympathetic comes from that autonomic nervous system. We have that gray commissure that goes through the center, and it connects the gray matter on the left and the right side of the spinal cord. Ventral roots. Those are motor neuron axons. Those are going out to tell your skeletal muscles to do something. Those dorsal roots is that sensory information that I said on the slide before. That dorsal root ganglion, or ganglia. I pointed that out in a picture a few slides ago. Said that was the cell body of sensory neurons. Then our spinal nerves. Our spinal nerves are actually made by dorsal and ventral roots. So sensory and motor. Our gray matter actually gets divided into somatosensory, visceral sensory, visceral autonomic motor, and somatic motor. Somatic motor, so sensory information from your muscles. Visceral sensory, well, that could be from your abdomen. That could be from any of your organs. Visceral autonomic motor, that's your autonomic nervous system working. And somatic motor, well, that's being able to move. So here's all the different parts. The blue is the somatic sensory. The green is visceral sensory. The yellow is visceral motor. And the red is somatic motor. Motor goes out the ventral side. Sensory is coming in the posterior or dorsal side. Here is that dorsal root ganglion. We have it on this side too, and this has all the cell bodies of those sensory neurons. How about our white matter? Just like in our brain, in the spinal cord, it is myelinated and non-myelinated nerve fibers. We have ascending, so they're going up. That would be sensory information. Descending, well, that has to be motor because anything that's coming down goes to motor, goes to muscles to tell you to do something. We also have transverse or commisual fibers. There are places along the spinal cord where nerve fibers transfer from the right side of the spinal cord to the left side of the spinal cord, or the left side of the spinal cord to the right side of the spinal cord. So we have to have commisual fibers that allows that to take place. We have columns or pedunculi. We have dorsal, lateral, and ventral white columns. So here are those white columns. You have that dorsal phenoliculus, ventral phenoliculus, and lateral phenoliculus. This shows you that dorsal white column, those are ascending. So they're going up to the brain. Here's some of the different tracks. You have spinocerebellar, spinothalamic, rubrospinal, corticospinal, pyramid tracks, reticulospinal, vestibulospinal, tectospinal. It tells you where they're going. Spinocerebellar, from the spine to spinal cord to the cerebellum. Spinothalamic, spine to the thalamus. Corticospinal, those pyramidal tracks. Going from the cortex to the spinal cord. They tell you right where they will go. So what happens if somebody has some kind of damage or trauma to their spinal cord? Paresthesia. So when we have some kind of damage to those dorsal roots, those dorsal are the posterior part, and the posterior part is sensory tracks. So you lose sensory function. Or paralysis, that's when those ventral roots, or motor. So we lose motor function. You get flaccid or spastic paralysis. Flaccid paralysis, that ventral roots and those ventral horns get damaged really bad, severely. So information does not go to the muscles. We have no control over our muscles then. So your muscles, since you can't, no nerves are working to your muscles, we talked about this in the muscle system. Your muscles are going to start to atrophy and get smaller. Spastic paralysis is because of upper motor neurons. Those are neurons up in the brain or upper part of the spinal cord. It's usually from that primary motor cortex. So the neurons in the brain and the spinal cord are fine. Muscles are stimulated by reflex, no problem. So the patellar reflex we talked about, that happens, no problem. But you can't voluntarily control your muscles. So your muscles shorten. If you have a transection, something that cuts your spinal cord in half, whatever level that spinal cord is cut at is where motor and sensory is completely lost to any region below it. So paraplegia, they'd have to have a transection between their first thoracic and their first lumbar vertebrae. They can't use their legs. And if it's at like T1, T2, even T1, part of their arm, because part of T1 still goes to their arm. But most of the nerves that go to your arm are from your cervical spine. And there's enough other nerves that feed the same area that T1 does in your arm that they can pick up the slack. That's why your arms aren't really affected. But you lose all sensation from pretty much your neck down if it was at T1, the base of your neck. Quadriplegia, that is where it affects the cervical region, which means you lose, quad means four, you can't use your four limbs at all. Spinal shock. It's where you lose function of anything that happens caudal or below the lesion, but it's only for a short period of time. It's not something permanent. Polio. Polio is due to a virus, that nice polio virus. It affects the nerves of the ventral horn. Those ventral horn, the anterior portion of the anterior horn, motor. So it affects those motor neurons. Your muscles atrophy because they're not working properly. They're not sending out information. People with polio may die from paralysis of their respiratory muscles, or they could have cardiac arrest. There's this thing called post-polio syndrome. And that's something that people who had polio, who did recover from it, experience years later for the rest of their life because they lost some neuron function. And as I said before, nerves don't repair themselves much at all. So you lose nerve function, you lose the ability of that nerve, anything to happen to that specific area. ALS, or Lou Gehrig's disease. That again affects the ventral horn. So motor neurons going out to tell your muscles to do something. And fibers of the pyramidal tract. Usually starts noticing they're tripping a lot more often. And it's a progressive, so it progressively gets worse. They lose their ability to speak after a while. They can't swallow anymore, and eventually they can't breathe anymore. They usually die because of asphyxiation because they cannot breathe. Their diaphragm and their muscles are not working to allow them to breathe. This says your book says death typically occurs within 5 years. I had a friend who passed away of ALS and he didn't even make it 18 months. 2 years is even stretching it from the initial diagnosis. He didn't last 18 months from the initial onset of symptoms, my friend who passed from it. So it is 5 years, I think, is kind of a stretch, but that's what your book mentions. It can be caused by environmental factors. Your genetics again. There could be some kind of mutation to the RNA processing. Has something to do with glutamate. This is the only treatment right now for ALS. This is probably what will have somebody last 5 years if they catch it like right away. Because usually it takes a while to finally diagnose ALS. It may not be as effective. So let's look at some of these neural pathways. Where nerves are going into the brain, coming out of the brain, what tracks they're following, what information gets sent on these different tracks. They all kind of do a lot of different things. So as we talked about, when we talked about the brain, there's places where there's desiccations or they cross from one side to the other side. A relay is where we have a chain of neurons. Remember how I drew that one neuron that went out? We have another neuron that'll connect to it. Oops. Another neuron that'll connect to it. Well, relay is a chain of these neurons going one to the next to the next. Somatotopy. It allows for precise spatial relationship in the central nervous system to spatial relationships in the body. Symmetry. Our nervous system is pretty paired, our spinal cord. What happens on the right, we're also going to see on the left. So we have first, second, and third order neurons. So we talked about that relay. This is what we're looking at. Is one neuron connecting to another neuron, connecting to another neuron. So these first order neurons, that's those cutaneous receptors, receptors at your skin, receptors at your muscles. They're proprioceptors, trying to help with your balance. They're going to branch and go different places as it enters the spinal cord and then into the medulla as well. They synapse with a second order neuron or an interneuron. Their cell bodies are at that dorsal horn, so the posterior portion of that spinal cord, or the medullary nuclei. Their axons travel up to the cerebellum or the thalamus. We have third order neurons. Those are considered interneurons as well, but their cell bodies are found in the thalamus. And they go into that somatosensory cortex. We do not have third order neurons in the cerebellum though. So our different pathways. There's different ways that information gets sent up to the brain. We have dorsal column medial lemniscal pathways and our spinal thalamic pathways. Spinal cord of the thalamic thalamus. That is discriminatory touch. Proprioception. We have spinal cerebellar that goes into that cerebellum and it ends. So let's look at these. Those dorsal column medial lemniscal pathway. That's sensory information to the cortex for touch and vibration. And it is made up of the fasciculus cuteus and fasciculus gracilis in the spinal cord and the medial lemniscus in the brain. Our spinal thalamic pathway. Pain, temperature, touch, pressure. That goes to the lateral spinal thalamic tract. Then our spinal cerebellar. Remember how we talked in that cerebellum about knowing where our body is in space? So our cerebellum can kind of give out information to the body based off of where you are in space. Well, that's where that spinal cerebellar tract comes into play, because that's sending sensory information up for what's going on with your muscles, what's going on with your muscles, your tendons, everything with your body to kind of help coordinate movements based off of what is already happening. So here's all these different pathways. You can see how information comes up, how it'll go and actually crosses the spinal cord at one point, and then it'll go up to the other side and where it'll go out. Or like this spinal cerebellar goes up and goes straight to the cerebellum. The spinal thalamic, you notice how it's coming from one side, it travels over to the other, and then it goes up to that side, the opposite side of the brain. So here's all the different pathways, where it's located, where it terminates, and what it does. Put all of these in here for your information. So how do we send information back out? Again, those pyramidal tracks sends information straight out. And then everything else is sent through indirect pathways. So we have upper motor neurons and lower motor neurons. These upper motor neurons are those pyramidal cells in the primary motor cortex. The lower motor neurons are those ventral horn, or that anterior portion of that spinal cord, those horns. That's that ventral horn, that motor. That's what goes out to their skeletal muscles. So those pyramidal cells, that they send information directly down. They're going to go through those pyramidal tracks, which is the lateral and ventral cortical spinal tracts. They don't synapse until they reach the end of their track at the spinal cord where they need to go. They'll synapse with an interneuron or a ventral motor neuron. That direct pathway regulates fast skilled movements. So here is the different ways things come out. We have these pyramidal cells, take everything down, and then it crosses at the level and it goes out to that muscle. We have our other way, crosses over, and it'll go out. Our indirect pathways or multineuronal pathways. Multineuronal, there's several neurons between. We have our brain motor nuclei, and it includes everything except for those pyramidal pathways. Your axial muscles, your balance and posture, coarse limb movements, your head, neck, eye movements, so you can follow something. Ever been to an eye doctor? They usually test your eye muscles, how well they work, by having you follow something, finger, pencil, something, just to see how you can follow. So we have reticulospinal, vestibulospinal, rubrospinal, and tectospinal. These all are indirect pathways that help move muscles. Reticulospinal and vestibulospinal, vestibular, balance. They must maintain balance. And your postural muscles. Rubrospinal, flexors. Tectospinal, head movements in response to visual stimuli. All that stuff we just mentioned on the slide before. So here's how they come out. You notice how they're going to cross. They go through that red nuclei, cross the spinal cord pretty quickly to the opposite side, and they go out to that muscle. So here are the descending or motor pathways. These are all in here for your knowledge. And here is all the different fiber tracks in an MRI of the brain. It's kind of cool where they all kind of go and how they're connected and interconnected together. It's a lot of cool stuff. So let's quickly look at how our central nervous system develops. We talked about it a little bit at the beginning, but let's go into more of the embryologic development. So, 3-week embryo, our ectoderm, is what is going to form our neural plate. It's going to form a neural groove and neural folds. These neural crest cells are going to migrate and help form those neural folds. As the grooves deepen, that's what forms that neural tube. So here is everything that starts the neural plate of that ectoderm starts to invaginate and form neural folds. Here's where those neural fold cells are going to migrate to form that neural crest, which will eventually form those peripheral nervous system structures. And that neural groove becomes a neural tube, which makes up the central nervous system. We have that neural tube by week 4. And it's going to differentiate into that central nervous system. By week 6, that spinal cord starts to have that alar plate and a ventral basilar plate. Alar plate becomes interneurons. Basal plate becomes motor neurons. Those neural crest cells form dorsal root ganglia. So here's this. You can see that basal plate that becomes motor neurons. Those alar plate become interneurons. It connects one to the next. And those dorsal root ganglia have those sensory neurons. So we have gender-specific areas in our brain. And they will appear at both the brain and the spinal cord. And it all just depends on if there's testosterone being secreted or not. If the mother is exposed to radiation, drugs, or certain infections, that can actually harm the developing fetus, that's our central nervous system. That's why they tell moms not to drink alcohol, take opioids. Even infections like rubella can cause problems. Smoking, because it decreases the oxygen levels in the blood. Nerves can die before the fetus is even born. Can cause brain damage again before that fetus is even born. That hypothalamus is the last area to develop. So if a baby is born prematurely, they can't regulate their body temperature well because that hypothalamus hasn't been fully developed yet. That visual cortex is going to develop over that first 11 weeks. Our neuromuscular coordination goes from a superior to an inferior, proximal to a distal direction. So from the head to the toes, the middle of the body out. Proximal, closer to the trunk, to further away from the trunk. So as we get older, just like everything else, your cognition declines. But it's not bad. It's not very significant until someone's in their 80s. That's when you really start to notice it. Your brain will start to shrink eventually. But if you use excessive alcohol, even boxing, can lead to senile behaviors that's unrelated to the aging process completely. Cerebral palsy. Cerebral palsy is a neuromuscular disability involving poorly controlled or paralyzed voluntary muscles. It's because of brain damage. Could be because of a lack of oxygen at birth. It can cause spasticity in your muscles, speech difficulties, motor impairment. You can't move things. Patients will have seizures. They're intellectually impaired. They could be deaf. Could even have visual impairment. So cerebral palsy can cause all kinds of problems. Encephaly. It's where that cerebrum and part of the brainstem actually never develop because they don't fold correctly. Encephaly is what leads to death because the brain never really developed properly in the first place. Spina bifida. Spina bifida happens because of the vertebral arches, that vertebral body? Bad drawing. You have the vertebral body that has the transverse processes, which has the spinous process, and then the transverse process on the other side. Still a bad drawing, but at least it's better. This spinous process in the back doesn't develop. So the whole back portion of that spinal cord is kind of exposed. It's when you see it, it's common in that lumbosacral region. So that lower spine, lumbar region into the sacral. It usually doesn't cause any kind of neural problems. There's sacral dimples, or you could have some weird patch of hair. That could be showing that there's some kind of underlying anomaly, that spina bifida. It could be severe and have the meninges actually protruding out of that spinal region, and they could end up with a sac-like cyst or a meningoceal. It could be a myelomeningeal if it's the spinal cord, nerve roots that protrude into that sac. They can have a large cyst, hydrocephalus, paralysis, bladder dysfunction. This is why food is infused with folic acid. A lot of our foods are infused with folic acid to prevent this because spina bifida was shown to be related to folic acid deficiencies in the mother. So by providing that folic acid, we are able to significantly reduce the amount of spina bifida cases in our country. And that is the end of the central nervous system. Thank you. Bye.